My name is Dr. Kirsty Protherough. I would call myself a Jerry GP. I'm also the director and chair, one of the directors and the chair of the Community Hospital Association. I'd just like to reiterate what Sue said. I never expected so many people to join a special interest group session tonight, but I'm really glad that you have. And any questions or comments that you've got to make, please put them in the chat. And it would also be useful if you could put what your role is as well within the chat when you ask a question. So today, the special interest group meeting is about utilising the diagnosis of frailty for personalised care in community hospitals. And so if we move on the slide, please, Eleanor.
Yep.
So a little bit about my background. So I qualified as a doctor in 2007 from the University of Birmingham. I worked in the University UHB Trust at the old Sally Oak Hospital within an elderly care firm as one of my rotations in my foundation year, which was really great. I worked with some very inspiring consultants within that role. Then in foundation year 2, I worked on the placement in elderly care rehab in Birmingham and West Heath Hospital, which has 4 wards. One's an orthopaedic rehab ward, one's the 3 general elderly care rehab wards. And again, I really enjoyed working with the elderly care team as part of that in that rehab hospital. Then I went into general practice. I went into general practice training, but still really enjoyed the medicine involved in elderly care. And I did the academic GP training in Birmingham when I did an MSc in primary care and community studies, which involved doing some heart failure clinics in the community and INR clinics within the community of primary care. And when I became GP, I've worked in normal general practice, out of hours, but I fell into the community hospital role at Evesham Community Hospital by starting off as a locum there. And because I felt slightly sort of isolated within my role as a locum in the community hospital, I completed the Diploma of Geriatric Medicine by the Royal College which is issued by the Royal College of Physicians, which is actually open to all advanced care practitioners now, which I think is good. So I did that just to ensure that I wasn't acting out of my scope of competence and to try and ensure best practice. Back then, actually, frailty wasn't a big buzzword as it has become now. I don't remember it being a large part of the Diploma in Geriatric Medicine, but it's slowly become more important in my work and in the community hospitals. And the word has become, it's not just a descriptive word anymore, but it's being recognised as a clinical diagnosis. So I carried on working in the community hospitals, took a salaried role there, became a clinical director in 2018, and I've mentored ACPs and their prescribing modules. And I'm currently a mentor for a nurse completing their advanced practice in Evesham Community Hospital.
Can I just, sorry, Kirsty, the audio for some of us is going a bit in and out. So sometimes you're clear and sometimes you go really, really quiet.
Okay,
I'll try why.
Is that better? Can you hear me better now, maybe?
Yeah, that's a little bit better. Sorry to interrupt.
Okay. No, it's fine. Sorry. Yeah, so I basically mentored some ACPs through their B300 prescribing modules, and currently a mentor to a nurse completing her advanced practice at Evesham Community Hospital, and I facilitate and support the Frailty module, which is run by the University of Worcester, and I'm a lecturer for new medical students at the University of Worcester. So I have general passion for elderly care and education, and I'm a member of the British Geriatric Society. So if you move on the slide, Eleanor.
Yes, sorry.
Thank you. Oh,
wrong way.
So I just want to say thank you so much to everybody for attending this session this evening. I know that everybody in the NHS is so busy and time is everyone's quite time poor really. So I really appreciate that. Appreciate the fact that you are how you filled in the survey that's sent out as well. So we've got a real mixture of people who've come tonight and working mainly in community hospitals. So 52% of the people who filled in the survey are working in community hospitals, which is as expected, but we also have other people who are researchers, other people working in community care, and other people who are service managers for integrated care boards, and consultants and geriatricians. So that's really great. If we just move on to the next slide, Eleanor, sorry. So we've got a real multidisciplinary attendance to our special interest group meeting, which is actually quite typical of our special interest group meetings for community hospitals. And I think that really reflects the multidisciplinary nature of our work with patients living with frailty, and the teamwork that surrounds when you are trying to provide personalised care plans for patients who are living with frailty. So again, I think it's great that we've got such interprofessional group in our special interest group tonight. Next slide.
Oops, sorry.
So again, there's a lot of people. There's many people here who have a lot of experience. People have more than 40 years experience within healthcare, 33 years. For those people who have less experience, hopefully this is going to be very useful for you as well. Next slide. So frailty has increasingly become, like I mentioned before, a clinical syndrome and not just a descriptive term. So the World Health Organization definition is it's a clinically recognizable state in which the ability of older people to cope with everyday or acute stresses is compromised by an increased vulnerability brought on by age-associated declines in physiological reserve and function across multiple organ systems. And from the survey, I can see that actually all of you who filled in the survey have a good understanding of what frailty, the just clinical syndrome, what it actually means. And if you just move on to the next slide. So this is an example taken from Rockwood, a paper that Rockwood has written about just sort of demonstrating that somebody living with increasing frailty, if they have a minor illness or insult like a UTI, that they can go very easily from being independent to being able to perhaps live on their own independently and look after their own personal care needs, to becoming dependent just from maybe perhaps a minor stressor such a fall as a UTI, as a chest or a chest infection. I'm sure when you're in your work, you see this frequently, people needing admission to hospital for relatively minor events that would not affect somebody who was fit or just mildly frail. So just move on. So why is this recognition of frailty and supporting frailty important in our work within the NHS and wider society? So the reason why this is becoming more important is because we have an ageing population in the UK. Life expectancy has increased substantially due to the advances that we've made in sanitation and medical science. So in 1981, the life expectancy at birth for a man was 70 years, for a woman is 76.9 years. In 2018, it is 79 years, and for a woman, 82.9 years. So with the aging population, we are living longer, but in some cases we aren't necessarily living healthier. So sorry. So we're not necessarily living in a more, we're not necessarily living in remaining in a dependent state as we age. And this isn't just a problem within the UK. The World Health Organization has announced a decade of healthy aging from 2021, and it's recognised that it's a global issue, the fact that we are living longer, but not necessarily retaining our functional capabilities. And so the decade of healthy aging from the World Health Organization includes promoting initiatives throughout society, not just in healthcare, but including the built environment, to help people live longer, but live better and have what they call a longer, healthy lifespan. So if you move on to the next. So again, this is a bar chart, which is from the Office of National Statistics, which shows that we are going to have substantially more people aged over 85 years in 2041 and 2066. And they're going to represent a much larger part of the total UK population. Okay, we move on. So what's the objectives of the special interest group? So the objectives are, how do we harness the objectives of this session is to look at how do we harness the power of the frailty diagnosis and including frailty scores to provide tailored care to our patients. And I'm going to speak through and give you examples of the results of the survey, which was conducted amongst a group of multidisciplinary healthcare professionals working in community hospitals and other care sectors, which I think sheds some light on your current understanding and experiences of frailty and how it influences care delivery. And by the end of the session, I hope we have inspired you and equipped you with some fresh perspectives on how you can leverage frailty scores, diagnosis, to enhance our provision of personalised care to patients living with frailty. So if you go on to the next one, Ellen. So regarding the frailty scores, so I think from the survey showed that you do have good understanding of what frailty actually means, but when it comes to frailty scoring, I think the results are variable. So familiarity with scores like the electronic frailty index, a timed up and go test, Prisma 7 questionnaire, the Edmund frailty scale were sort of an average. So half of you were familiar with them, half of you weren't. So they weren't quite so well known as the Rockwood frailty score. So if we go on to the next slide. So the Rockwood frailty score showed that more people are much more familiar with the Rockwood frailty score, or what's also known as the clinical frailty scale, which we're going to concentrate on tonight. So, regards to the Rockwood frailty scale or the clinical frailty scale, the CFS, there's varying confidence, but most people are more confident than not about using the Rockwood frailty scale. Okay. And regarding your current role and how frequently you use frailty assessment tools in clinical practice, I was actually surprised to see that actually a majority of you, despite the familiarity with the frailty scoring, that the majority of you actually didn't use them regularly in your clinical practice, and about 26.1% frequently, about sort of 30% use them frequently or always, and 17.4% occasionally. But I was quite surprised that the majority was rarely or never, actually. And again, as I suspected, the most, is it just going through, Eleanor?
Sorry, Kirsty. Yes, my apologies. And the next one on.
Yeah, so we've gone to the next one. So why Rockwood? So I'll ask the question why Rockwood was more popular than the others, and some of the answers were: it's easy to use, well recognized, it's easily taught to juniors, and it's a validated tool. And validated means that it produces reliable results. Some people noted that it's the one that they've determined that they should be implementing, probably because of its ease of use, and it's also frequently included in frailty training. It's a visual chart, and it's commonly used. Sorry, Eleanor, does it keep?
Yeah, sorry, Kirsty.
Okay, so if you just go to the next slide. So the history.
Oh, sorry.
So the history of the Rockwood score is that it was developed in a research and epidemiological setting for the Canadian study of health and ageing, and it has been rapidly uptaken and adapted into clinical practice. And it's a 9-point scale assessing an older adult's overall fitness or frailty, so it mustn't be used in patients who are less than 65 years. It's scored by clinicians, and higher scores indicate greater risk of frailty. It's not a questionnaire, but a judgment-based tool, and it focuses on easily observable items. And the important part about the Rockwood score, clinical frailty scale, is that you should try and use it, use use it to judge their baseline level, not when you see them during acute admission. So what their Rockwood score, what they're normally like. And so this is particularly important in clinical settings when somebody's admitted acutely. They look very different to how they normally look. So you can actually make them, if you judge their baseline at a much lower level, then your care plan won't really be suitable for them, because you won't be judging them on what you need to get them back to if possible. So we'll go on to the next one, Eleanor. So this is the pictorial, this is the clinical frailty scale, and it shows you that it goes from 1 to 9, 9 being terminally ill, and 1 is very fit, 2 is fit, 3 is managing well, 4 is living with very mild frailty, 5 is living with mild frailty, 6 is living with moderate frailty, 7 is living with severe frailty, 8 is living with very severe frailty, and then it gives you descriptive terms which describe what each of those mean. And then also it's got some important caveats about scoring people for frailty who have dementia. So if we go on to the next one. These are some Kaplan-Meier curves which come from the original study by Rockwood in 2005, which shows clearly that the probability of survival is much higher if you have a lower clinical frailty score. And then the higher clinical frailty scores show that your survival your probability of survival is much lower over the preceding months if you are increasingly frail, which is intuitive, and you would expect that, but it's actually quite useful to actually look at the evidence. So if we go on to the next slide, and then this was another part of the study which shows the curves showing the probability of avoidance of institutional care is much higher if you're fit, obviously fitter. If you've got a lower clinical frailty score, then the higher your clinical frailty score, the more likely you are to need institutionalized care in the preceding months. Okay. And then this is another chart which I've got from the Clinical Frailty Network, which is based in the UK. And so it shows on one side, it shows the clinical frailty scale grade, and then it shows some important data regarding predicted outcomes. So it shows that, again, it's quite intuitive, but it's useful to see the evidence. So for people who have severe frailty, for example, they have a longer length of stay, they have a higher readmission rate, and they have much higher inpatient mortality. And there is a big jump between clinical frailty scale 6 and 7. So they're all used columns which suggest how you should manage patients with different clinical frailty scales. So the fitter they are, the more it will be about prevention and self-care and trying to avoid frailty and put things in place to ensure that they don't go into the frail state, like remaining active, ensuring they comply with vaccination programs, and looking after their long-term conditions. But then the increasingly frail they are, the change to thinking about palliative care and symptomatic control. And this data is coming from an acute setting. So that data is coming from talking about inpatient mortality in acute hospitals. So the next one. So this is another switch I've taken from the network, which talks about outcomes from intensive care units using frailty as a predictor, again using the clinical frailty scale. And it shows, again, and this is looking at several studies in different countries and ICUs, that the increase in the clinical frailty scale correlates with an increase in ICU mortality and 30-day mortality. So again, this kind of information can help you with ensuring that your care plan for the patients is appropriate with regards to their outcomes based on the clinical frailty scale. So the next slide is so next slide shows that unfortunately,
Kirsty, you've gone. Sorry to interrupt, Kirsty. Your audio's gone. Don't know whether it's the signal.
Can you hear me better now?
Yes, I think so. Yeah.
Yeah. So the data, I could not find the data for community hospital relating frailty scores and outcomes in community hospital settings, and therefore I feel more research is needed. I have got some examples of some relevant ongoing research by Professor Catherine Evans, who may be here tonight. If you are here, it'd be useful to just, if you could put it in the chat, Catherine. So she is a professor who attended our Community Hospital Association AGM in 2019 and updated us on some important research she was looking into large sets of community hospital data and outcomes, and wasn't using the Rockwood score, but other types of outcome measures. And even in unstratified population data and at large sets of data regarding community hospitals, it shows that 1 in 4 patients admitted to community hospitals had died within 1 year. And I think this research is ongoing, but I think it's just useful again to know, to be able to guide care and resources for patients admitted to community hospitals, because we've got some information which is evidence-based on likely outcomes. Okay, so if we could move on to the next slide, please. So when I asked you as a group, what is the primary purpose of using frailty assessment tools in your practice, it was the most popular response was to guide care planning, resource allocation, but also people are chosen to identify patient at risk of adverse outcomes and to inform treatment decisions. And other purposes of using frailty assessment tools that you wrote down were, one was to satisfy some NHSE directive. So that's perhaps suggesting that it was more of a tick box exercise than actually useful. To aid screening and prevention of worsening frailty, and to help support patient expectations. So I just wondered what your thoughts are about how you use your frailty assessment tools, if you do use them in community hospitals, and how it helps you with your sort of personalised patient care planning.
Hi, Kirsty, it's Sue here.
Hi, Sue.
So, hi, in Cornwall, we have the Community Assessment and Treatment Units, which is based around a lot of work we did with frailty in trying to bring people in to prevent them going through the front doors of our emergency departments and into the acute sector. So we really did hone in on that frailty score and Rockwood, and I think we look at it a number of times through a person's journey on whatever pathway they go on. So it's very, very useful, and it's something that our nurses, our therapists and our GPs use.
So you look at the Rockwood, and the higher the Rockwood score, the increase the frailty. How does it affect you? Just less likely to send them into the acute hospital? Is it?
I don't know whether it's less likely for us to send them in. I think we probably stretch our limits as far as we can to try and keep people with us for as long as we can. But essentially, yeah, using the two, and obviously clinical symptoms and observations of that particular person.
Yeah. Okay, so if we move,
Can I just share how we use it in our community hospitals?
Yes.
So I'm a geriatrician. I work across 3 community hospitals, and we base our initial MDT on the clinical frailty score that they had prior to their acute admission. So their baseline function sort of 2 weeks before, when they were at their good self before they had the acute episode. Our community hospital beds are mainly stepped down from the acute hospital. And we do have occasional step up people from the community where we will assess their clinical frailty score. Our acute hospital is still learning how to do CFS scoring. So often we have to sort of work it out based on their prior function. And then in the MDT, we will use that to help us guide our MDT expectations and also the patient's expectations for their likely ability to engage with the rehab. So, for example, we might expect someone with a clinical frailty score of 7 to perhaps participate in lighter rehab or take slightly longer to rehab than someone with a clinical frailty score of 5. Or if they've been through a very large health event that's been life-changing, but they have a lower clinical frailty score, for example, a 3, then we'll be putting them through gym and doing a lot more in a different way with them, because our expectations are very different because of their baseline function. We don't keep reassessing the clinical frailty score because we're basing it on their physiological reserve, so how they were when they were at that baseline before the acute event that changed them.
That was really helpful. It was that Jane speaking.
Yeah.
Yeah. Which community hospital? Where are you based, Jane?
I'm East Suffolk, and so it's Aldborough, Felixstowe, and Bluebird Lodge.
Thank you. That was really interesting, and I think that's probably how a lot of community. Well, I think I would have thought that's how quite a lot of community hospitals work. I mean, in Worcestershire we note the clinical frailty scale on admission, but I'm just not sure how much we keep referring. How much we refer back to it. And mention it during the MDT sessions. Has anybody else got anything else they'd like to add?
Hi. I'm Sam Vaughan. I'm an ACP working in community hospitals as well. I think a couple of my team are on the call as well. So we started using the CFS a couple of years ago when we first started our role, and we're trying to roll that out to the rest of the MDT. And at the moment we're using it to focus on advanced care planning for those patients that have got a clinical frailty score of 7 or above. And again, we work that out we look at their CFS from 2 weeks before their acute admission. So often they've come to us from an acute hospital, but we look back at what they were before that acute admission and that acute event that brought them into hospital. And then what we'd like to move towards is patients with a 5 or a 6, looking at doing a more thorough CGA on those patients, looking at how we can better manage their long-term conditions. So that's our plans at the moment. We're sort of in the middle of it all, really.
No, thank you. I think I'm just writing all of this down so I can put it in a report for the special interest group after this session. So thank you for that contribution. Anybody else got anything else that they'd like to say how they use it at the moment within their community hospitals? Okay, so if we go on to the next slide, Eleanor. So if we just go on to the next slide, is that okay? Okay, so one of the things that I do is support the University of Worcester online e-learning frailty course, and this which was actually pioneered by a Jerry GP called Maggie Keeble, and this is a slide taken from the online e-learning frailty course, which is talking about the proactive approach that you can use based on the Rockwood frailty scores, which I think both of you have really just alluded to, which is the lower the clinical frailty score, your approach will be different to the severe frailty score of 7, 8 or 9. So if you've got, as you just said, a severe Rockwood score 7, 8 or 9, then you would be focusing perhaps more on advanced care planning, hospital admission avoidance, and having those respect decisions, and having robust escalation planning to try and help avoid unnecessary hospital admissions, which may not be helpful in that particular to those people who are living with frailty at that level. So if you just move on to the next slide. So the other thing that goes along with frailty, clinical frailty scoring, and has become increasingly important, I've noticed over the last few years in caring for patients living with frailty, is asking what matters the most to patients, and asking them what are their priorities. And I was just wondering how many of you consistently in your practice ask patients what matters most to you? Is that a question you're frequently asking your patients when they're coming in your care?
Yeah, we have started to use it in Cornwall, probably not on every ward, but what matters to you is the basis of how we start off with our assessment once we start to talk to that person once they hit the ward, because what our goals might not be anything like what that person wants to achieve while they're with us. So I think if we're going to do personalised care, we can't do it without asking what is really important to you. And I guess one way of explaining that, on the stroke ward not so long ago, we had a young man, and it was really quite young. All that man wanted to do was to learn to play his drums again. So, you focus your therapy and support and rehab with him, and we managed to get that, and he just sailed. He just flew then once we started to look at what he wanted to do with his life and to move forward with his stroke.
Yeah, I've noticed that when I worked in stroke rehabilitation at Evesham, I noticed that quite frequently, that if you can help patients achieve what matters most to them, then it can really help things like their mood and their engagement in rehabilitation. It's just finding that one thing that really appeals to them can help. I was just wondering if anybody else has asked this frequently on the ward round, or looks at it in MDT specifically. Hi, so Kyle.
Hi. Yes. I can't see you all. Yeah, hi, sorry again. Yes, we do that. And what we've done is we've started on a couple of wards having the board that's near the bed. What matters to me is one of the questions there. And we a similar case to what the other person said. We had somebody who was in his 90s, and he was a retired Oxford professor, and his priority wasn't to stand up and walk at all. He actually just as long as he could be hoisted into his chair and have his old students round and have intellectual discussions, that's what he wanted. Wasn't interested in learning how to stand or walk or move at all. So yeah, that was an interesting one.
Thank you. And so obviously that would have affected his sort of plan and his goals, and changed what your discharge planning arrangements would have been.
Yeah, absolutely. It's like, let's get him home. As he said he had the money to employ carers to hoist him around, and let's get him home. Let's not try with the rehab so much. Let's just get him home on his terms and what's most important to him.
Okay, great, thank you. Those are both really good examples. So if you just go back to the slides, Eleanor. So this was just a slide which I was looking at for research in this area about what matters most, and this is talk about what matters most in an acute care setting, and it's just a research paper where they've looked at what patients have said has mattered most to them, and it involves things like they divide it into two categories: autonomy and functioning, and then they've talking about things like making decisions as desired, being able to go home, receiving the desired information, being able to do enjoyable things, being able to care for loved ones, feeling better in general. So I've just put that paper in there as an example of when you actually ask patients what matters most to them, it might not actually align with what you perhaps think is should be the priority. So if we just move on to the next slide. Okay, so the other question I had was about the comprehensive geriatric assessment. So that's another important part of my role when I was working in a community hospital with regards to assessing patients. And it actually said, so the question was, do you use the comprehensive geriatric assessment in your current role? The majority of people who filled in the questionnaire said no, and 20.8% said yes. Some people said we're aiming to implement it within the organisation as part of a programme. Some people said they're not officially in a comprehensive geriatric assessment format, but they're covering the aspects of the assessment. So if we go on to the next slide. So I just wanted to bring that all together and it show that you've got the clinical, so with the assessment for patients in community hospitals, I think you've got the clinical frailty scores, Rockwood, and if you, the comprehensive, which feeds into part of the comprehensive geriatric assessment, and then there's what matters most to the patient and their patient priorities for their future care and wishes. So there's several things which actually feed into making a personalised care plan for a patient, and focusing on what matters most, I think, is so important. It is really important to ensure that you're getting the right outcome for your patient. If you go on to the next one. So when I asked you about, has anybody got any questions or any thoughts on that? So Kylie Locke has said advanced care planning as part of the end of life care has supported our approach with personalised care too. It's really a really powerful tool. Okay. Okay, so the next slide, Eleanor. If you could. So that's fine, that's the right slide. So when I asked you about the challenges that you face with regarding using frailty tools within your work, some of the responses I got were there's departmental challenges, which means, for example, changes in changes in the systems that you're using, the computerized systems, the turnover of the junior doctors, and their rotations. So, for example, in Worcestershire, GP trainees were on 4-month rotations. So, actually, trying to keep them up to date and keep them updating them every time a GP trainee rotates actually takes quite a lot of time. The other thing was some people put some of the challenges have been healthcare professionals struggle to sometimes achieve a consensus about what should be actually used, and there's varied awareness and confidence in using the frailty tools. And also there's difficulty sometimes in people understanding the relevance of them, which I hope in some way this special interest group meeting will help. And there's also a wide diversity of assessments. Some other issues are standardisation efforts and issues with clinical coding, and the time constraints which are there in certain care settings. So, for example, primary care, you have very short time with your patients, and there isn't often time to complete these assessments to how you perhaps would wish to. And also then there's consistency. There's sometimes a lack of consistency across the different care sectors, as well as a lack of continuity between care sectors. So the next question asked was, have you received formal training in the use of frailty assessment tools? And actually the majority of the responses said no, again, which is quite surprising considering how important they are becoming in care of the elderly. And next slide, if we can. Then other questions I asked were about how your findings and plans for patients living with frailty are communicated between care settings and sectors. And as you can see, the responses were a wide variation of responses, which I think shows a general lack of standardization across the sectors and how the personalised care plans for patients coming out of community hospitals are actually communicated. So if you just click the next button, Eleanor. Yeah, so I've put there, no standardised practice for patients living with frailty. Okay, so if we move on to the next slide. So as a result of the survey and doing research for this session, thought about what are the solutions for improving the use of frailty school tools for personalised care. So one of the obvious ones was the lack of, which I don't think would be too difficult to address, the lack of formal training of frailty scoring. So I think it is clear that there is a lack of formal training. So exploring frailty training opportunities is something that could relatively easily be done. I'm not here to promote the University of Worcester online frailty course, but the University of Worcester we do an online frailty course, as does the British Geriatric Society has an e-learning course in frailty, and the NHS e-learning for health has courses related to frailty. And again, I would say that our Community Hospital Association Special Interest Group is a forum where we can discuss many aspects of community hospital care, but a lot of it obviously is related to patients living with frailty. So the next slide. So the other one was now trying to find a solution for the lack of standardised practice across sectors and settings. But again, I think there needs to be more collaboration between the sectors, so between acute care, community care, and primary care. And perhaps joint training sessions, and also not forgetting social workers and carers could also be more involved in training sessions and education, because again they are a key part of patients' care plan who are living with frailty. Sorry, Anna, can we just go back? Thank you. The other one is the lack of continuity and standardised practice would probably be helped by integrating IT systems. It's clear that the many personalised care plans and care plans are held on multiple different IT systems, and how that gets communicated between sectors I don't think is clear, actually. And as a GP in normal general practice, it's not really clear to me, if I go and see a patient on a home visit who's living with frailty, where can access, perhaps if they've had a comprehensive geriatric assessment and frailty scoring, where I'd be able to access that information, whether it be on EMIS or not. And the other thing was standardising high quality education and training of frailty, I think is really important. And again, sessions like this and with people collaborating across the UK, again, that will, I think, really help with improving education. And if you go on to the next one. So the other issue was, I think there needs to be, we had a really good special interest group session about research in the community and the foundation trusts, and that would include community hospitals. And there needs to be more research into the use of frailty scores relevant to our patient populations within the community, and more research in general, which is relevant to the patient populations that we are caring for in community hospitals. So there is generally a lack of research that we can generalise to our patients that we look after. And I think on a previous special interest group session, which was ran by Christine Burt, who has pioneered Community Healthcare Alliance Research Trust called CHART, which you can join if you are a community or foundation trust, to help you improve and promote research within your organisation. I think the NIHR is recognising frailty as an important area, and I think there'll be more funding for research in this area in the future. And also the Community Hospital Association Special Interest Group, we've received funding from the Health Foundation for our Q group and our Q study, upon which we produce research about best practice and innovation in community hospitals during the COVID pandemic. Okay, if we go on to the next one. So, if you go back. So again, I think to improve our understanding of frailty tools within community hospitals and our use of them and how it can help us with personalised care plans, again, continued collaboration between professionals will help us share best practice, network, and have open dialogue about the opportunities and challenges we face with our patient populations in a supportive environment. And if you join the SIG group, you will receive SIG event notifications via email. And we're also hoping to have a community hospital conference in the future next year, again, which will hopefully provide some educational events about best practice in community hospitals. And we have an innovation and best practice awards where you can share your initiatives with the Community Hospital Association and be part of the awards. Oh, if you go, so if the other thing I was thinking about this earlier, about the other thing about frailty is because it is a descriptive term, I think it is something that carers and patients and relatives can understand. But with the caveat of some patients and many patients do not like being described as frail. So the term that we need to use is patients living with frailty. So I think, but the fact that it's something that they do, I think they do understand relatively well what it means, that we need to continue with collaboration and co-production with patient participation groups, League of Friends, there's League of Friends that are based in community hospitals who also have pots of money that they might want to provide for. Depends what the rules are, but perhaps research as well as into frailty as well as equipment. And again, having more collaboration and co-production with the communities, and community hospitals sit within communities. So I think it's, again, they have a great opportunity there to co-produce and collaborate with the communities which surround community hospitals as to how they can provide personalised care for patients living with frailty. So Lucy's just saying, the British Geriatric Society resources are great for senior clinicians. And yes, thank you, Lucy. So what I can do is when I can put all of that information in a special interest group as well. So yeah, so best teaching is face-to-face or interactive webinars. E-learning doesn't work at all. Yeah, so what we do with the online the University of Worcester e-learning is we do have catch-up days, but there is an online e-learning resource. But what we try and encourage the participants in to do is relate everything to their practice. So relate what they're learning from the e-learning resource to their practice. So absolutely agree. Living with frailty versus frailty. So people, yeah. So people don't like, it's, people really wouldn't like, I think most people wouldn't like being described as being called frail. And I remember I did make the mistake of doing that once, and they were they were upset, and I had to apologise, and I don't think I ever used it in that manner again. But the problem is sometimes their relatives do describe them out of earshot in that manner sometimes. So Eleanor, if you just, can I have the next slide, please? Thank you. So Yeah, so thank you. Thank you to everybody for attending. I'm sorry with the issues with the tech and the microphone. If you've got any further questions or comments you want to make, or I'm happy to hear them. Thank you.